anywhere else? Maybe kind of, sort of. You know that the body, and one of the things that I want you to really know to take from this is that the body is mostly made up of water. So you've got to understand that we quickly become dehydrated when we don't replenish that water. We mentioned that, right, with when we talked about heat stroke and heat exhaustion. Remember that? And how when we sweat and we lose electrolytes and lose fluid balance. Now in the spring, the very first time when you come back from Christmas, it's kind of torture. When you come back from Christmas, I'll be teaching you fluid and electrolyte and phase balance. And that's probably one of the hardest things that you're going to learn in nursing school. It's very difficult. But we're going to talk about fluid imbalances and how it affects different conditions in the body. But you can understand that if we lose a lot of fluid and lose a lot of electrolytes, then it affects our heart, it affects our brain, it affects our kidneys, and the way those things function. What is it about this time of year, too? The heat. You know, one thing I always think about is these poor high school football players or athletes. You know, when I go home in the afternoon, I live in the China Grove area, so when I go home in the afternoon, I always see South Carolina, they've got them running down the road, and I'm thinking, oh, you know, they're losing, they're sweating, all that stuff. And the football players, they got pads on, it's 90-some degrees outside, and so it's really easy for us to lose those essential nutrients. We also have to rely, of course, on carbohydrates, protein. What is protein really good for in the body? What do we use protein for? Muscles and tissue repair. And that's something to keep in the back of your mind with nursing, is that anytime you've got a patient who's in the hospital with a wound, who's in the hospital for surgery, we need to make sure that they have a large amount of protein, because that's what's going to help them heal, and that's what's going to help that tissue to repair itself. Okay? All right, what about fats? We have to have fats, don't we? Fatty acids and fats, very important. Then there's the micronutrients, all the different vitamins, A, D, C, D, and then the minerals. And we're not going to go into great detail on any of those, but just know that those are important for the body. The next couple of slides, when you read through them, they talked about how we digest things. Why do you think it's important? Now, I said we're not teaching you to be nutritionists. Why is it important for us to know any of this, though? To know how it affects the body, to know what to recommend for our patients to eat, what we need to increase their nutrients, right? What about digestion and stuff like that? What if we have a patient who came in for, let's see, maybe they have a really large peptic ulcer, and so wouldn't that affect digestion? And so we need to know those kind of things, don't we? We need to know how is their current condition affected by what they take in. So it's really important. Okay, this is digestion, absorption, metabolism, carbohydrates, and I'm not going to read that. Protein. Again, we talked about protein is important for tissue repair, and it is important, of course, for muscles. One of the biggest muscles, of course, is the heart. And we want to make sure that the heart gets enough protein. Right? Okay. Now, I'm going to skip through because I want us to look at developmental considerations. When you're doing a physical assessment on someone, we've learned about how to assess each individual part of the body, right, from head to toe. But there are some things that you're going to have to ask that you can't necessarily readily see. And one of the things that you're going to need to ask is, how is their diet at home? How are they eating? Infants, of course, need more breast milk or formula early on. They do not need water. That is one of my biggest pet peeves, and when I teach you guys OB, that's one of the things that I'm going to point out to you, is that a newborn does not need water bottles. And you'll see a lot of people out in public your mothers, your grandmothers, your aunts may have told you that, oh, just give them a water bottle. Well, what happens is if you give a baby a bottle of water instead of a bottle of formula or a bottle of breast milk, is that they get full of water and then they won't eat. And so you have a lot of babies, a lot of infants coming in for weight loss or failure to thrive, and it's because they're not eating the needed calories. So that's one of the things that you can promote, one of the education tools that you can promote, is that babies get enough water through formula and breast milk. They do not need water bottles. Okay?
Just in regards to that, what if you're living in a particularly hot climate and you're out and about with your infant a lot and you know they're still eating every couple hours, but is there still a need for that? Or
Still no need for water.
at what age does that change?
They do not need water, plain water, until they're a year old.
Really, even if you're in a hot climate and you're out and they're sweating? Okay.
Yeah, they should be getting plenty through other means.
I've seen a lot of them take apple juice and water that down.
Yeah, and let's talk about juice too. Juice for infants should not be introduced until they are at least 6 months of age, until you're starting to introduce more solid foods. So addition of solid foods between 4 and 6 months. Juice should not be, because juice contains what? Sugars. Even the baby juices, even the infant juices that you can buy, contain sugars. So they don't need that. They don't need all that extra sugar. And watering it down does not really help much. It does cut some of the calories, but that's it. The American Academy of Pediatrics also recommends that infants not drink juice out of a bottle. That if you're going to give juice at 6 months or older, that it be in a sippy cup. Because a nipple, that rubberized nipple, traps the sugars, and it keeps the sugar on their teeth, and it will promote teeth rot, tooth rot. If you've ever seen a baby with bottle rot or tooth rot, you never want to see it again. It's horrible looking. I've seen you'll see babies out in public with black teeth, or teeth that they have to get pulled, and that's called bottle rot. That's what that is. Another cause of that is letting them go to bed with a bottle. Never, ever, ever. That's a very bad practice as well. Letting them go to bed with a bottle also promotes tooth rot, but it also can contribute to frequent ear infections. Because as they're laying down and they're holding that bottle, the milk can dribble back into the ear canal, and it gets trapped, because the infant's ear canal is not formed like ours is. So it gets trapped and it promotes ear infections. So that's another thing. Another nutritional consideration to remind everybody is that babies do not need cereal at 2 weeks old. Now I know my mother gave me cereal. She said, "Oh, that's how you slept through the night." Yeah, well, they're finding that introducing cereal too early promotes allergies. So those of you who have really, really bad allergies, you can ask your parents if they gave you cereal early. Yeah. They're finding that it does promote allergies. Cereal does not need to be introduced either. The problem with cereal, again, is that it's bulk. It's a bulk food. And so what it's going to do is it's going to fill them up, and they're not going to eat as frequently. And that's, of course, what our parents and grandparents wanted, is they wanted everybody to sleep through the night, right? Instead of waking up every couple of hours to eat. And that's what happened, is that they bulked up their intestines, their stomach, and then they didn't eat. The problem with that is that they're not going to gain weight. So no cereal either that early. And then, of course, the other thing to remember about nutrition with infants is that we do not introduce whole milk until the recommendation is a year old. I have seen some pediatricians say 9 months, but a year old is really when you need to introduce cow's milk. Babies, the intestines of an infant cannot digest cow's milk, the actual milk enzyme. So those are just some things to remember nutritionally when you're talking about infants. So when you bring them in, a newborn should eat every 2 to 3 hours if they're breastfed, every 3 to 4 hours if it's formula fed. 3 is the average. We like to see 3 hours. Okay, and then, of course, introducing solid food. Do you know what you should introduce first, vegetables or Vegetables or fruits? Vegetables, right. You introduce vegetables first so that they don't get used to the sweetness of a fruit. Okay? And all of you are probably thinking, well, Lord, my parents and grandparents did everything backwards. And some of these things are habits that we have to break. Some of these are just old school thoughts that we have to break, and you just have to get real strong and stand up for them. Okay? They aren't going to like you for a while. All right. Any questions about nutritional needs for a newborn or for a baby, an infant? Okay, let's talk about toddlers. They get kind of picky at this stage, right? I remember Ben would eat green peas. He loved green peas, baby food green peas. And then when he started eating real food, he wouldn't touch a green pea with a 10-foot pole. So they start getting a little bit more picky at this stage, but they're also more active. So their calorie requirements have increased at this point because they're starting to toddle. That's the word toddler. They're starting to toddle and walk around, and they're using more energy. Okay? You start seeing food allergies at this stage because they're trying new things. So when they come in, that's one thing that you need to make sure that you ask is, do they have any allergies to food? Not just medications, not just seasonal allergies, but food allergies, because that's when you're going to start seeing it at this point. Something else is that their need for iron and calcium has also increased. Formula is what? It's iron fortified. Okay, formula is iron fortified. And if they're breastfed, then they should be getting plenty of iron as well. After they go off formula, though, that need for iron is just as high, and they may not be getting it in as much high amounts as they were when they were getting formula. So you need to make sure that they do have iron. They do have those baby vitamins or toddler vitamins, the little gummies, and those are really good for making sure that they get what they need.
How old until they start taking those?
This age, toddler age, 3, 4 is a good age to start those. Most infant baby foods and the Gerber, they make the little baby raviolis and stuff like that now. They fortify those with iron. It's when they start getting to table food that we start having to worry. So when they start really eating mostly from the table. Preschoolers, eating adult foods, very active. They need snacks between meals. Okay. Now at this age, they can have that water that we were limiting when they were infants. They can start having water to drink. Because they're drinking with their meal mostly. They're not drinking as a meal. As an infant, a bottle or drinking is their meal. But if you give them a bottle of water, again, that fills their little stomach up. And an infant's stomach is very, very tiny, so we don't want to fill it up with something that has no calories. Any questions about preschoolers? When do y'all go to Partners in Learning? The 20th, so we've still got a couple weeks. Okay. All right, school-age kids, protein-rich foods. Really important to make sure that they have breakfast at this age because they're going to school. And of course, it depends on what time they eat at school. Last year, I know Ben's lunchtime was 10:30. Who eats lunch at 10:30?
My daughter's in kindergarten. She goes lunch like 1 o'clock.
Yeah. So
She's in first grade.
she goes at 1 o'clock. Yeah, so Ben now goes to lunch at 11:30, which is a better time. But at 10:30, that's breakfast time, and then they've got to go the rest of the day without anything to eat. So really making sure that they have snacks when they get home is important because they're going to be hungry. Making sure that they have a nutritious snack too, that it's not a little Debbie cake or something like that. Anything that anybody wants to throw in about school-age kids that you've noticed? They're getting better with foods in schools. I think they're getting a little bit better at offering. They still don't require them to eat it, though.
They have to offer it to them. They have to offer it to them.
They have to offer it, right, but they don't necessarily eat it.
If you think it's getting better, it depends on, I guess, what area you're in. Because now they're offering more healthy choices in high school and things like that, but they cut down the amount. So teenagers are not getting the exact amount
That they require.
of food that they require, and they go hungry.
Yeah.
For combating it.
Right. Yeah. There's a lot of issues with school foods. There really are. I know that Ben will come home. He came home the other day, and I said, "What did you have for lunch?" He had macaroni and cheese and corn. I said, "Well, that's helping right there." That's so. School age, it is hard. I don't know many kids that want to take their lunch. Y'all might have some that want to take. He doesn't think it's cool to take his lunch, so he wants to eat at the cafeteria. After I've eaten lunch with him a couple of times, I would rather take my lunch, but yeah. So anyway, but just making sure that they do have a balanced diet and get what they need. That breakfast they always say breakfast is the most important meal of the day, and it is. Making sure that they have something before they go off to school is something to keep them alert, keep them active. All right, adolescents, and he just brought up about, tell me your name again, please. Jeff. Jeff just brought up about adolescents and high schoolers, and you're right. They do not get what they need, I don't think, a lot. And what they do eat is a lot of junk food. I think they're trying to take some of the vending machines out of schools now. The drink machines, aren't they trying to come out of the schools now because of those sugary drinks, those soft drinks? So making sure that those aren't there, that we're limiting some of those junk foods. I remember my mama saying to me, because I was really thin in high school, and I remember her saying, "It's going to catch up with you. It's going to catch up with you." Anybody ever hear that? And boy, did it catch up with me. It did. And, but we're more active when we're adolescents. So if you've got a child who's also involved in sports or after school activities, they do need to have, we mentioned football, but I remember, I was not in the marching band, but I remember watching them and all that equipment that they had to carry and all that. I mean, that's hot as well. So any kind of after school activity that they're really sweating and really using those calories. Growth spurts is something else. They're still going through growth spurts at this point. So with a growth spurt comes increased need for calories. Another thing I want to point out being a pediatric nurse too is this anorexia and bulimia may start to occur. They get really, they've got it under adolescence, but I've seen it start a lot younger. Kids who are more concerned about their weight that are young, 8 years old, 9 years old. I think that's sad. I don't think that they need to be. We need to encourage that. Also, we are seeing boys coming in with anorexia and bulimia. That's not just a female problem. There are boys out there with the same thing. So. I'm not going to go over eating disorders. You've probably heard a lot of these, and you will talk about it when you do psych again. So I just wanted to introduce it to you though in these slides to know as well that it does affect our quality of life and it does affect our physical self too. So if you've got a patient who comes in who's nutritionally deprived because of an eating disorder, you're going to see some abnormal physical characteristics. If they're not nutritionally sound, when we're talking about physical assessment, what kind of things are you going to see in the physical assessment?
Their hair and nails.
Their hair and nails are going to be brittle and dry.
You can probably start seeing their bones a little bit more or something like that.
Okay, their bones are going to become more porous. They're not going to have the calcium build up in their bones.
Have issues with the guts and feet.
Gums and teeth. Gums and teeth. What else? What about any kind of wounds or cuts or scrapes? Would they be healing properly? No. So when you're doing your physical assessment, look at those kind of things and wonder to yourself or think to yourself, keep it in the back of your mind, are they getting the nutrition that they need? We went up to adolescents, but what about adults and older adults? That's just as important, isn't it? Our nutritional requirements don't stop just at adolescence. Okay, and there's anorexia and bulimia. We're going to flip through those. Y'all recognize any of these people? I remember in high school we had to watch the Karen Carpenter story, and it was horrible. Okay. Yeah, she died, lost down to 80 pounds. Died of a cardiac arrest at the age of 32. Margaret Hemingway, 41. Christy Henrik, she weighed 60 pounds when she died at 22. Those are sad stories. Very sad stories. Which one? It's 30. It should be 30, not 3. It should be 30. She started really young. Really, really young. Yeah, it should be 30. Yeah, she did. Yeah, she really did. Okay, so, imbalanced nutrition is a thing that you're going to need to consider when you're doing your care planning with your physical assessment. That's something. Okay, adults, we talked about that their nutritional requirements do not stop. Postmenopausal women, what is the requirement for postmenopausal women that we need to keep? Calcium, right, calcium, so that they don't get osteoporosis. When estrogen declines, the need for calcium increases because estrogen protects the bones, and if estrogen is gone, then those bones start to become porous, spongy, soft, and then we start having breaks. So definitely making sure that they have enough calcium and vitamin D. They're finding, there's studies out all the time on all these other vitamins and minerals about C, A, C, and E, about heart disease, cancer, preventing cancer. So making sure that those vitamins. One thing, though, that you need to make sure of when you're talking to your patients about their nutrition is making sure that they're not taking too much of any of this stuff. It's important to supplement with daily vitamins, but it's also important not to take too much. You can become toxic on some of these things, so you want to make sure of that. Bless you, bless you. Older people, our metabolic rates slow down now, so we need fewer calories at that age, but they still need the same amount of things: carbohydrates, protein. Okay, this slide is actually old. This is the pyramid. You know now that they have the My Plate. She talked to you about My Plate. It's a really good site. Did y'all go to that site? Yeah, it's a really good site, and I think that's a nice way to look at it. When you think about a plate, it's also, I think, easier to teach children because they can think of it as a plate and what is required on that plate. I meant to go in and change that slide. And nutritional assessment. Y'all already done that with Ms. Beaver. Measuring, you can actually check. These are ways to screen with the calipers over there. We talked about that at the very beginning, about the calipers, checking skin folds assessments. The BMI, which is, ugh. Who would ever want to know that? These are just some poor pictures. Look at those teeth down there for vitamin C deficiency. Did y'all see that? How they've worn down. Spongy bleeding gums. So you're going to see when you're doing your assessment, these are some things that you also need to look for. Okay. Did y'all have any questions? I know we just breezed through those, but like I said, you're going to get more of that, and you got a lot of it with Ms. Beaver. Did you have any questions after you read through that? Again, the biggest thing that I want you to take from that is just the basics. The body is mostly made of water. I think there's a question about BMI. What is BMI? That kind of stuff. So basic stuff, not anything major. Did y'all do your nutritional assessment on somebody at home?
No, here.
Oh, you did it here? Okay. All right, this is the one that I really wanted us to look at really closely. Assessing for comfort, pain, and sleep. Okay. So everybody kind of find this. I really wanted to look at this. This is a very important concept right here. Pain is the fifth vital sign. Have you ever heard that before? When we think about vital signs, we think about blood pressure, temperature, pulse, respirations. When you are doing your vital sign, and the reason they say that pain is the fifth vital sign is that what you should do is when you're getting your basic information, when you go in the room to do your morning vital signs, you should include asking them if they're in pain. Are you having any pain? Okay? Now, one thing that you're going to learn too when Ms. Walker talks to you about nursing process is that there are two types of nursing diagnoses that you're going to be looking at. You're going to be looking at physical things, like physiological, but you're also going to be looking at psychosocial. Pain, you would think, might go on the physiological side, but it's not. It's psychosocial. Pain is what the patient says it is. What does that mean? It's subjective, so that each one of us may have a different idea of what a painful experience might be. Do you see that in your everyday life? Have you ever seen that? Some people do not deal well with pain, period. They just don't. They may have a little cut on their finger, a paper cut, and it's the end of the world. And then some people may have had major surgery and you would never know it. They deal so well with the pain. So pain is what the patient says it is. What that also should tell you is that when you're assessing pain, you never should put your own interpretation of what pain is on them. If you go in the room and they are laughing and talking to someone on the phone, but yet they tell you that their pain is an 8 on a scale of 1 to 10, you shouldn't go back out in the hall and say, their pain is not an 8. They're in there laughing and carrying on and talking on the phone. They may just be someone who deals well with the pain, okay? Or maybe their theory is, I'm going to ignore it. I'm not going to think about it. I'm going to talk on the phone and distract myself from it. So don't ever assume that just because someone's acting that way that they're not in pain, okay? So they may not be demonstrating the signs that you think they should be demonstrating. All right, there's two types of pain. Does everybody know this? Acute and chronic. What would a broken arm be? Acute. That's something that has happened. It's a one-time thing, hopefully. It's a one-time thing. And it's short in duration. When the arm heals, the pain should go away. Versus someone who has colon cancer. What would that be? It's going to be chronic. They're going to be in chronic pain, or bone cancer, something like that. They're going to be in chronic pain, so the pain lasts a long time. It's a longer acting type of pain. Okay. And again, with chronic pain, people tend to learn how to deal with it. So you may have someone who has chronic pain, but doesn't demonstrate the signs and symptoms of pain like you think they should. Do you know people like that? Yeah. Okay, some things that affect pain: ethnicity and culture. There are a lot of cultures that think you should be very stoic when it comes to pain. And then there are some cultures where they're very loud when it comes to pain. They cry, they moan. Developmental stage, we're going to talk about that in just a minute. Environments. And then past pain experiences too. A lot of people will relate their current pain. What that means is a lot of people will relate their current pain to something that they've experienced in the past. If you've ever had a kidney stone, for example, I've never had one, but my mom has, and she says it's worse than birthing a child. So if you've had a kidney stone, you've had several. So, huh?
I've had a few.
You've had a few, so you know how bad the pain is. So there you go. So he's always going to tell me your name again. Jason. Jason. Okay. He is always going to. I'm going to get y'all's names eventually. He is going to constantly relate any future pain experiences to that pain, and he's going to say, "Well, this is nothing compared to kidney stone pain." Okay, so that's what they're saying, is that you relate it back to something else. Okay, this is something you're going to need to know for the test. And so I really wanted us to look at it. This colder mnemonic. Okay, it's a way to describe, when you're getting someone's history, doing their physical assessment, it's a way to describe their pain experiences. Okay, so I really want you to know this. All right, so for example, C describes the sensation of the pain.
So C is supposed to be for sensation. I don't understand this one.
So
Characteristic. Yeah, characteristic. Describes the sensation. So is it sharp? Is it burning? Is it aching? And ask them to describe it. How does it feel? Describe how it feels for me. Okay, characteristic. O is when it started, or onset. When did it start? Onset. L is for location. Where does it hurt? Now remember, we talked about, and I think that My Baby is in Pain case study also mentioned this too, that there are younger children, little ones, 2 and 3 year olds, are not going to be able to locate pain like older children can. They can't, if for example, if it's a referred pain, they're going to go to the referred location, not the actual location. Okay? They're going to have a harder time locating. Okay, D, duration. D is for duration. Is it constant, or does it come and go? Okay. E, what makes it worse? Okay, what makes it worse? Does movement make it worse? Does coughing make it worse? Does sneezing make it worse?
That's escalation.
Escalation. Sorry. Okay. R, what do you think R means? Relief, right, relief. What makes it better? What makes it better? You know, a lot of people say for migraines, for example, they say put ice on your head or put ice on your neck. Some people, though, ice does not help. Some people like heat better. That's okay. There's nothing wrong with that. When you are, it's specific to you. So what makes it better? Don't assume that the same kind of thing for pain is going to work for everybody. And then R. What do you think the second R is? Radiation or referred. Some people call it referred too, like referred pain. Radiation or referred. Does it start in one location and move to another? Okay. A lot of people talk about the pain of a heart attack as a radiation or referred pain. It starts in the jaw and works its way down the arm, the left arm. Of course, that's classic. Not everybody has that same kind of pain, but heart attack. The pain of labor. A lot of women talk about it starts in the back and moves towards the abdomen. That's a radiation or referred pain. Gallbladder pain. I know when my gallbladder was bad, it referred to my shoulder a lot. Okay? So I really want you to understand about colder. And that it's just a way to understand how to describe that pain. Okay? All right, and this is subjective. Okay, other things to obtain that go along with that colder mnemonic. Anything that comes along with your pain. When anybody have migraines in here? What other symptoms do you have? Nausea and vomiting. Okay, sensitivity to light. Blurred vision. Okay. So a lot of those are associated symptoms. They come along. The pain is so bad it makes you nauseated, or the pain is so bad that it causes that sensitivity to light, or the floaters. A lot of people refer to floaters across their eyes. Okay, so there's other types of symptoms that go along with it. How does it affect your daily living? You know, some people can work through their pain, and then some people, the only way to get rid of it, such as with a migraine, is to go to bed in the dark, in the quiet. That's the only way they can get through it. So how does it affect your home life? Okay. The meaning of the pain to the person. There are different ways to describe pain. Coping, how do you cope? Effective response. Okay. All right, pain scales. Now this is something really important as well that I want you to get. The different pain scales. When you go to the hospital, and again, remember, pain is the fifth vital sign. So you go in the room, you're taking your vital signs, you're getting your blood pressure, temperature, respirations, pulse. The fifth thing is to ask about pain. Now, if it's someone who is coherent, you can say on a scale of 1 to 10, with 10 being the worst pain you can ever imagine experiencing, or you have ever experienced, what is your pain right now? Okay? And then have them rate it. Okay? Traditionally, anything up to 4 would be considered mild pain. Moderate pain, 5 to 8. Severe pain, 8 to 10. The reason that that's important is because you're going to have some physicians who order different types of pain medicines for different types of pain. You may have 3 different pain medicines ordered, and it'll say, give this for mild pain, give this for moderate pain, give this for severe pain. So according to what they rate on the scale is what you're going to administer. Okay? All right. Now, the FACES scale down at the bottom, has anybody ever seen that before? Little FACES scale, it's very cute. There's also a scale called FLAC, F-L-A-C-C, FLAC. Don't ask me what that stands for, because I don't know. The FLAC scale is an observational scale, and that's the next slide that we'll look at. What those are trying to show you is children, again, remember children can't tell you on a scale of 1 to 10 what their pain is. So it's by observation. What are they doing to make you think they're in pain? Are they crying? Are they restless in the bed? Are they moaning in their sleep? Are they not eating? Maybe maybe it's a small child and they have stopped eating. Okay, what other things can you think of that a child might do if they're in pain? They're clingy. They want to be held a lot.
Holding that body part.
Holding that body part or guarding. Now the FACES scale was created for you to actually be able to show it to a child. You would show them these faces scale, faces. You show them these faces, and they are supposed to be able to point to what they feel like. You show them these smiley faces, and you say, which of these is how you feel right now? Would tell me how you feel right now. And they would be able to point to it ideally. So what age do you think you could use that with? 4, 5 and up. I wouldn't go too young because that would be hard for them, again, to describe. Maybe about kindergarten age. That age would be your FACES scale. This one is more of like the FLAC scale, and it's hard to see on the slide, but what it is pictures of children's faces and how they look. So you would look at the child, and then you would determine, that's what FLAC is, by what they're doing. But are they grimacing? Are they frowning? Are they crying? Or what are they doing? You would then determine what their pain scale is. And that's called the FLAC scale, F-L-A-C-C. Okay? So that's just another way to determine by pain. So when you go with me to PEDS in the spring, one of the things that you're going to always assess is pain. And you're going to do that with adults too. Again, you always assess pain, always. Okay. Objective data. Objective data is data that, the first one was subjective. The colder scale, that's subjective because that's what they're telling you. Objective data would be like what? What you see, what you observe, the data you gather, their vital signs. What do you think is going to happen to their vital signs if they're in pain? It's going to increase. Their blood pressure traditionally increases. Their pulse traditionally increases. So you may have someone that's telling you that their pain level is a 3, but yet their blood pressure is 165 over 92, and their pulse is, 110. So by looking at their vital signs that it's not really matching what they're telling you. So maybe they're mentally handling the pain better than their body is handling the pain. Okay. Okay, we talked about behavioral changes. You'll talk about nursing diagnosis with this walker, so we're not going to worry about that right now. Okay. Pain treatment. I mentioned that a lot of physicians will order different types of pain medicines. For mild pain, they're going to order an NSAID traditionally, which is your nonsteroidals, your ibuprofens, your Tylenols. Those are for mild pain. Moderate pain, they may add a narcotic, such as Lortab or Percocet, some of those by mouth. And then severe pain, that's when they're going to add in your morphines, your Demerols, your Dilaudids, your more opioid type analgesics. Your goal, what would be your goal as a nurse with pain medicines?
To keep it at a minimum, but minimize the pain.
okay, to keep it at a minimum, minimize the pain. You don't want to constantly be drugging them, right? You're not constantly drugging them. So your goal as a nurse is to go from getting them not needing those opioids, those severe IV pain medicines. That's your goal. You may be starting there, but they can't go home on that. And that's one thing that you need to stress with your patient is, yes, that morphine does act really quickly, and then boy, it takes it away really quickly, but you can't go home on that. So maybe this time let's try the Lortab or the Percocet, the one that's the narcotic that's just for the moderate pain, and see how you do. Okay? So that's your goal, is to work them down so that when they go home, they're able to manage that pain on their own. Okay? All right. Let's take a little break, and when we come back, because I want to talk about the difference between addiction and dependence when we come back. So take about 10 minutes or so. When you become addicted to something, there's a lot of factors that play into addiction. It can be genetic. You can genetically be predisposed to becoming addicted to something, pain medicine, alcohol, anything. So it is a chronic disease, and it's something that does not go away easily. Addiction is a very serious thing. There's the behaviors are up there listed for you: impaired control, drug use, compulsive use, craving. Okay. There is a term also called pseudo-addiction. Have you ever heard of that before this? Pseudo-addiction is an addiction that comes from under-treating pain. And some physicians under-treat pain. So that they appear to be constantly needing or craving medication, the patient does, but it's because they're not getting enough. Does that make sense? If they were getting what they needed, then they would not have that craving or need for the pain medicine. So it's not that neurological or psychological problem condition as a true addiction. It's only because, it appears to be, but it's only because they're being undertreated. Make sense? You understand the difference between the two? Okay.
If someone has an addictive personality and you give them pain medicine, how do you regulate how much to give them?
And that's a very difficult thing to do. Some physicians will not give them narcotics because they know that maybe they were already addicted to alcohol at one time in their life. So they will not give them a narcotic. They'll try other methods before that. So it's hard. There's a fine line there. But then again, you don't want them to suffer either.
Right.
Okay, dependence on something means that it is similar to addiction. Dependence, though, you may have that withdrawal syndrome where when they withdraw from the medication, they do show issues. They become adapted to it. They have to have it to survive. You become dependent on something. And then tolerance. The problem with tolerance is that, for example, maybe you know somebody who has fibromyalgia and they have been on OxyContin for years and years and years and years and years. Eventually, that OxyContin's not going to work anymore for them. The pain is not necessarily that the pain has gotten worse, but that the medicine has stopped working. That's tolerance. So that's a problem with people who have to take chronic pain medications, is that after a while, you start limiting what you are able to take because you've taken everything and you become tolerant to it.
Do you ever become intolerant?
I've never been like a fast. I'm sure if you wait long enough. Okay, so what about pain in children? This is beginning when I was little.
No.
It's like up here. is circumcision. Used to they would do circumcision without anything. Because they would say, oh, they don't really feel it, it'll go away, They found that neonates do feel pain. The actual labor process is painful. Some infants, that's the reason that they don't tolerate labor well. Because if you can imagine being squeezed through the birth canal, this little tiny birth canal is a painful process. If your head was being squeezed, your skull was being rearranged as you're being squeezed through the birth canal, you know that it is a painful thing. So they are trying different methods with neonates now. They are numbing the foreskin of penis as they're doing the circumcision. We're using sugar water. I don't know if anybody has seen that before, little sweeties. There are studies that have been found to show that sugar stimulates a part of the brain that will shut down pain, that will shut down the pain receptors. Wicked weird. So anytime we do any kind of procedure on a newborn, we drop sugar water in their mouth, and it does nothing.
So do diabetics not feel pain?
Well, you wonder about neuropathy and stuff, and that's the cause of that. We know that the sugar coats the vessels and that's dead, so that then you wonder. You think about all these things. Okay. Do you think it's true or not that infants remember pain episodes?
False.
It's false. They really don't. If you ask your 4-month-old, or if you don't ask them, your 4-month-old gets shots. They go in for their regular immunization. Okay. Then you ask them when they're 4 if they remember shots. When they don't. They really don't. Which is a good thing, right?
Can I ask a question about that? But don't they start to associate certain environments with
They do start to
unpleasant
associate it.
experiences and stuff like that, even at like 4, 5, 6 months? So is there still a level of remembrance, even if it's not long-term through life?
It's not, they're not remembering the actual pain, they're just remembering that something happened when they were there that wasn't fun.
Right.
So it's not really the actual sensation of the pain, they're remembering it's the unpleasantness of it.
The only reason I would say that I would believe that's not true is when my oldest daughter was young, she had to have RSV injections, and at a week after she got them, she would have night terrors. She would wake up screaming and holding her leg where she got the injection.
How old was she when she was doing that?
She was 2 months early, so the time she was born.
Yeah. There are cases like that that you hear of. Traditionally, they don't, but I think when they're having frequent procedures done, then I think they may then start to associate that pain. And then you wonder too if there was still pain at the time. If she was still feeling injection pain, if the muscle was still feeling the pain. Okay. My ex-husband tells me that he remembers when his dad died, and his dad died when he was 18 years old. He remembers that feeling that you hear things like that, and I don't think it's a bunch of bunk, but he may. You don't, so I think a lot of that is association too. Associate a lot of things in that situation. Okay, what do you think? Is it true or false? Parents rarely exaggerate child's pain level. False. They do. We as parents don't want to see our child in pain. And again, it goes back to that very first couple of slides that we talked about, is that everybody has their own interpretation of pain. If you are someone who does not tolerate pain well, then you're going to think, oh, well, my child's is going to be hurting as bad as I would be hurting if this happened. So they don't intentionally do it, but you never go by what the parent tells you. You go by what you're seeing. Okay? Remember we talked about the Flack scale and behaviors of the child? That's what you need to go by, not what the parent tells you. On pediatrics, when we have children who have PCA pumps, the patient-controlled pumps, where you push, and we do have some sicklers who come in, sickle cell patients who come in, and they get on PCAs. We always instruct the parents, you do not need to be pushing this button. They don't get a PCA unless the child is old enough to understand and push the button when they're in pain. But we always tell parents, you're not responsible for pushing these buttons. They need to be the one to push the button, because they're the only ones that can tell whether or not they're in pain. Parent does not need to be injecting their own interpretation of pain. But it's hard. As parents, it's hard. It is. Okay. Children rarely become addicted to pain medication. That's false as well. If you've got a child who is has chronic illness, yes, they can become addicted to pain medication, just like we can. And children experience the same pain post-op as adults. It's false in that everybody, again, goes back to everybody experiences their own interpretation of pain. But yes, they can experience pain, but it may not be the same type of pain that we do. So again, what I want you to take from this is that everybody feels pain differently. Has their own interpretation of pain. When we're talking about children, they do have a lot of behavioral changes. We've already mentioned some of those. Okay. Most children, again, young children, can't tell you exactly where it hurts. They just know that they hurt. Especially little ones, little infants or toddlers. Okay. Look at that baby. Yeah, that's obviously a sign that they're hurting their little face. They're not happy. This is a table I was doing. More or less, toddlers can understand the concept of more or less. Does it hurt more than your tooth coming out, or those kind of things? You don't give them a lot of choices. That's the thing about the basis scale. That's the nice scale. You don't want to give them more than 3 choices. They only can understand if they become a male.
So that goes the same with people who are like dementia.
Yes. You don't want to give them too many concepts. But at age of 8, they can describe it a little bit better, give its location. They're going to use words. Their words may not be the same as yours, but you can interpret what they're saying. Okay, some other things that we can do besides giving medication, and I really want you to, I don't know if I would send this to you guys again, everybody comes once together a while. I don't want you to become so task focused that the only thing you think you can do as a nurse is to go in and medicate somebody. Okay? Pain medications are great, but we also need to try methods as well. That fits for anything. Okay? So you've got your distraction. We talked about the sucrose solution, the sugar solution, guided imagery, relaxation. I don't know if anybody can hypnotize anybody. I used to work with an instructor when I first started here that told me that when she went into, or when she was pregnant, and everybody goes to the Lamaze and stuff, she went to somebody who taught her how to hypnotize herself. So that when she went into labor, she would hypnotize herself and feel the pain.
Did it work?
An interesting way of doing things. Application of heat and cold, remember that that's not the same for everybody. Just because ice packs work great for your headache does not mean it's going to work great for another person's headache. They may do better with hot things. So, all right. Any questions about pain? Does everybody understand?
How would you take in developmental considerations? Because I know, like last year when we had that bicycle accident, and the nurse tried to use the base scale on my son, he came in, yeah, and he's nonverbal. So he came in walking bow-legged, face blotchy where he'd been crying, couldn't sit down, so he was guarding his behind. These are all things I see. I don't know if she noticed them.
Yeah, and again, the basis scale would not work with that.
But when she asked him which scale are you, he points to the happy one. And she says, so you're not in pain? And he shakes his head, but he's obviously in pain.
Well, and the thing about the innocent, precious. If you ever get to know him, he's just autism. And that's something else you have to take into consideration, not just developmentally, but with autism, they can't process things like we do. So you wouldn't want to use the FACES scale. I would never have used that with him. I would use the flattened observation. Instead, he's guarding, the way he's walking, obviously he's crying, he's burning. So that's something else you need to think about too, is their developmental stage. Very, very important to remember that as well.
So use maybe something like that with
Like
them.
the flag scale is what I would use.
So are you saying that you don't take what a parent says into consideration when they say that their child is in pain because they know their child better than you do?
They do know their child better than you. Yes, you can say that they're in pain, but don't take their word for how severe it is. You use your observational skills, and that's what you need to do as a nurse, is learn to recognize when there's other signs and symptoms that they may not be thinking of. Because of the fact that everybody has pain differently. If you tell me your child's in pain, I'll believe you that your child's in pain, but I don't want them in there over-medicating their child either. So there's a fine line there. And again, we as parents, we don't want to see our child hurt. Remember we talked about temperature? Remember how I said that the best thing to do is actually let the temperature go? And how many of you inside you went, because you're thinking about having to, let your child go with 130, 104 temperature, and you're like, oh, I can't do that. Because you don't want to see them suffer, do we? We don't. We don't want to see them miserable. However, there's a fine line there. Because if we continue to keep that fever down, it's going to only prolong that illness as well. So there's a fine line. Yes, you can believe a parent when they say their child's in pain, but you don't want to let that parent over-medicate them as well. Something that we use at Northeast on my unit is Child Life. We use Child Life a lot. They're absolutely essential part of our unit, and they're child psychology thinkers is what they are. What they do is their goal is to help that child developmentally remain intact while they're in the hospital. They use distraction techniques. We don't do any procedure on the unit without a child life person. So when we're starting an IV, they're in there with bubbles and books and the iPad and those brain sticks, where you turn them upside down and they bite noise and all that stuff. They use all those distraction techniques to keep them from feeling, or to keep them from watching the IV stick, the IV start. Many a time I've gotten through with whatever I was doing, and the child hadn't even noticed because they were too busy looking at the iPad or whatever it wasn't. So they are an essential part, and you can use a lot of those techniques in children. Distraction and other things. If they get bored, I don't know how your children are, but when Ben gets bored, everything's falling apart. The world's just falling apart. So, it's the same thing with pain. If you keep them distracted, we have the Wii at the hospital, we have Xbox, we have Guitar Hero, with movies, computers. They think they're on vacation. I've had a lot of children tell me they don't want to leave the hospital because it's so much fun. We have pet therapy, we have the dogs coming up there and playing with them, we have playrooms, we have everything you can think of. And so those techniques are distraction techniques, and it's keeping them from thinking about why they're actually there. So something to think about in your own environments too at home. Okay? Any other questions about pain? Everybody kind of understand the concept. I really want you to pay attention to the color mnemonic. I want you to understand that. So if I ask you, what is the characteristic, what does C describe as these, I want you to be able to study those.
Is there a distinct difference between a child that's scared and crying?
Very good point.
And
pain.
pain.
Very good point. Very good point. There he is.
They're scared, they quit.
Sure.
And
And a lot of times also as a parent too, when we're, for example, starting an IV, a lot of times they hate being held down more than they hate the actual stick. Same thing, has anybody in here ever seen a circumcision? Seeing it is actually worse, I think, than it actually procedure now, especially that they're numbing it, because they literally strap them down to a hard board. And, you know, and you think about a newborn, you know, their newborn is in a flexed position to begin with. That's how they like to be. So they strap them down to a hard board with straps and leave them like that for a while it's healing up. Now, I'm a big advocate of circumcision, so I'm not saying that I don't believe in it, but they are crying and screaming because they're taped down to the board. That's not, you know, that's why so yes, there is a big difference between the crying of being afraid and afraid. What do you think about, do parents make it worse?
Yes.
Yes. Whew, yes. Parents, sometimes I would much rather do the procedure without the parent in the room, because the parents are crying, oh honey, it's going to be okay. The pain's going to go away in a minute. They make it a lot worse. If you go in there with the attitude that it's going to be over quickly, we're going to be okay, you know, blah, blah, blah. It's like going to the dentist. I don't know that anybody really loves going to the dentist, but if you start your child out thinking that going to the dentist is the most horrible thing in the world, then what are they going to do every time you go to the dentist? They're going to cry and scream, aren't they? Because you made it that way. So yes, I think that you've also got to help them to understand that it's going to be okay. On the other flip note of that, you never want to go into a room with a child and say, if you're going to give them a shot, that this is only going to be like a little bee sting. Have you gotten That's a big old bee. You know? So, yeah, also be careful what you say when you do. Or don't say, this isn't going to hurt at all. I mean, seriously. So, there's some realistic. Okay. All right. Sleep, what we all like, right? No sleep. If you've been in the hospital lately, it's almost impossible to sleep in the hospital, right? Especially when you work there. Very hard to do, yes, very hard to do. A lot of things affect sleep. And your patients, when they're in the hospital, their sleep they're going to have some level of sleep deprivation, unfortunately. We, I think, are getting better at scheduling tests and stuff, not at 2 in the morning. We're getting a little bit better at that. But the hospital, unfortunately, is an environment that is a 24-hour environment. Okay, so we need to think about that. There's a lot of factors that affect sleep. Hopefully you saw that. Illness, of course, environmental, life. There's that third shift, and I worked third shift for a long time. You never really, I don't know if you realize this, anybody work third shift in here? Yeah. You never really, your body never really truly adapts to third shift, no matter how long you work it. And I don't know that I realized how bad I felt until I wasn't working third shift anymore. Until I was actually on a regular schedule, I didn't realize how bad I actually really felt. So your body never really changes. It does affect your sleep cycles. Stress, of course, stimulants, diet, smoking, medications. There's a lot of things. You do know that the need for sleep decreases as we age. The elderly don't need as much night sleep as. That's why they're up so early in the morning, exactly. But they do frequently nap during the day as well. Now, I can nap all the time, personally, but whereas young children need more hours of sleep. Okay. I'm not going to go into all the physiology of sleep, but you all know all that. And I'm not going to ask you questions about this kind of thing on a test. This is not what I want to know. Okay? I don't care about this. I want to know what you're going to do as a nurse. I could care less if you understand about the physiology of sleep, other than the fact that how important it is. Okay? It's the brain. Y'all don't recognize that? Let's go. Exposure to darkness. Very important. What can we do in the hospital to promote that? Darken the room, turn the lights out, close the blinds, pull the door. What about the hall lights in the middle of the night? Dim them, right, dim them. In the middle of the night, that's a very important thing, is to try, I mean, you don't want to wander around in the dark all night, but dimming the hall lights and the lights at the nurse's station, those are really important things to do as well. I used to work with a little nursing assistant, she's cute as a button, Miss Pauline, and bless her heart, she was like 80. And every night, she worked 11 to 7. You remember Pauline? Morning? Miss Pauline. Oh, bless her. She would come in, she worked 11 to 7. She would come in at 11, she would go in to get her vital signs, and we just gotten this dementia patient to sleep. And she flipped that light on. And of course, they were wide awake at that point, and we had to start all over again. So it is hard, isn't it? It's hard in the middle of the night to get those kind of things taken care of. But exposure to darkness is really important. Your circadian rhythm is important. We talked about body temperature. Y'all were real worried about that. But we do know that temperature, the biggest thing is temperature does decrease during the middle of the night. I don't care what hour it is, specific hour, but you know that it rises throughout the day. That's one reason that temperatures, when you're sick, are highest in the afternoon, because their temperature already is rising, right? So you can always tell it's a virus because their temperature goes up in the middle of the afternoon. Okay. You should have a regular sleep-wake cycle by 3 to 6 months. Some of you have had children think that's a bunch of bunk.
Especially if they have colic.
Yeah. Technically, they're supposed to sleep 23 to 6 months. The functions of sleep, those are all the different things that split through that. There's the sleep patterns for newborns. That's being as a baby. Real cute little thing. Cutie patoot. Yeah. He's real cute now when his nose isn't in his DS. I don't ever see his face. Do y'all have kids like that? Their face is always in their DS or their iPod or something like that. But newborns should sleep 16 to 18 hours a day. Would that be nice? Okay, infants. They're gonna gradually. This is being asleep in his jumping thing. They're going to have more periods of wakefulness at this time, infants. This is when you start to see their little eyes open and they're smiling at you and all those fun things. As they age, by 6 months, most infants sleep through the night, we hope. Daytime naps are important. Toddlers, 12 to 14 hours. Most still need an afternoon nap. Nighttime fears become more common during this time. Nightmares, right? What's sleeping under my bed, the bumps in the night, what's in my closet, and it's not Monsters Incorporated. Preschool, school age, 11 to 13 hours of sleep, 10 to 11 hours of sleep. I think kindergarten is a really hard time for a lot of kids because they went from daycare, where they still took naps every day, to kindergarten. Now they don't. I remember kindergarten, and we had to take a nap to school every day, and we took a nap. Yeah, we took a nap in kindergarten. That doesn't happen anymore. You do not nap at school. Those of you who don't have a child yet in kindergarten, that is non-existent anymore. They start them from the very beginning, and that's hard, isn't it? It's hard for those little ones who were used to taking a nap every day. They need to go to bed a lot earlier at night, yeah. Adolescents. Do you think most adolescents get 9 to 10 hours of sleep at night? No. Few actually get that much sleep. Adolescents tend to stay up later and wake up later. I hear a lot of people say that their teenager will sleep till noon the next day and go to bed late. We have a problem with this at the hospital a lot on peds, is that our adolescents want to stay up all night, and we have to try to get them back into a rhythm. Okay, adults. Most healthy adults need 7 to 9 hours of sleep. Do you think you get that? No. 3 to 4? Woo! And we talked about the elderly. They tend to go to bed earlier and wake up earlier. Okay? There are some problems when you're doing an assessment on your patients and asking them about sleep. There are some conditions. Insomnia can mean any of those things. Difficulty falling asleep, waking up frequently. More common in older people and females for some reason. Insomnia tends to be a problem. There's a set of conditions called parasomnias, and those include your sleep terrors, your sleepwalking. There is a difference, does everybody know, between sleep terrors and nightmares? Okay, nightmares are not as serious as sleep terrors. Sleep terrors are pretty bad. Sleepwalking, sleep talking. Anybody a sleepwalker?
My husband.
Your husband?
He cooks outdoor meals.
Cooks meals like
In his
sleep.
sleep?
That's scary.
Now,
Like, what she's doing,
when I first, now, I don't know if this is true or not, but if somebody's sleepwalking, you're not supposed to wake them up.
You're not supposed to wake them up. Yeah, it can cause a jump in their condition. I've heard that it can even cause a heart attack if you wake them up too
I was
quickly.
told not to wake them up during a sleep terror either, just to comfort
You're not,
them.
you're supposed to let them go. Yeah, sleep terrors, but sleep terrors often, sleep terrors are bad, so bad that they end up having to have some kind of therapy.
What makes you have sleep terror?
Different kinds of things, any kind of stress, physical illness can cause sleep terrors.
My mother-in-law has sleep terrors and she just like screams.
Yeah.
Like, so if you're asleep and you hear somebody scream, you think, oh my God,
Yeah.
somebody's being killed. And they told her, they told my father-in-law to try to check her blood sugar in the middle
Right,
of a,
yeah.
I don't know how to
It's,
do that.
but physical conditions, those will
But
cause
she's
those.
diabetic, so they think maybe her sugar is dropping and that's causing her to act crazy.
Yep.
Sorry, I don't mind sharing. I have sleep terrors, and I've dealt with it for years. That's part of my PTSD, but I have noticed now that when I wake up, right before I wake up, when I'm dreaming, I can feel my heart racing, and my heart rate is actually what wakes me up.
So you know that
And
it's.
so when I wake up, generally my heart rate is well into the 170s. So that's another thing with me, but like I said, after years, I've noticed that right before I'm gonna wake up, I can feel my heart racing and my.
And yours was as well PTSD? Yeah, so there you go.
But
So
because
again,
of that, I can't take any kind of sleep aid.
Right.
Because then I can't wake up from my.
exactly.
from my nightmares.
Because if you don't wake up, then that your heart rate's going to continue to go up. Exactly. So there's a difference between that and having a nightmare. Most of us have a nightmare, we wake up, we go right back to sleep. The sleep terrors are very difficult to go back to sleep afterwards. You're physically exhausted because you have had this terrors. Very big
Days
difference.
Afterwards, I have a hard time even going to sleep.
Yeah.
Because mentally I'm drained.
Right.
But I'm afraid of my sleep terrors.
Exactly. Yeah.
It
So
causes a lot of other.
It does.
devastating things.
it does, and that's why I said a lot of people end up having to go to some kind of therapy sessions because of it, because it drains you. You're physically drained. Sleep apnea, does everybody understand about what sleep apnea is, hopefully? What are some of the signs and symptoms of sleep apnea? Snoring. What else? Huh? Daytime tiredness, daytime sleep, falling asleep, headaches, memory problems, irritability. Okay. There are different types of sleep apnea, obstructive, central, mixed. We're not going to talk to you about that, but just to let you know that there are different types. Okay. Healthy individuals who don't sleep. Any of these things look like you all? What do you think? When you're doing an assessment, of course, you're asking them, just like with pain, you're just asking them to describe it. How do you sleep? How many hours do you sleep? Do you feel like you sleep well? Do you have difficulty getting up in the mornings? What about rituals? Are they important? Yeah. I personally have to have the room dark and no noise. But my son has to have the TV on. He has to have some kind of noise. Drives me crazy. I cannot sleep with any kind of noise. So, ask them about that and try your best to follow the same type of ritual while they're in the hospital. There are some things, you want to make sure that they don't do before they go to bed. Exercising right before bedtime is a bad thing. Everybody knows about caffeine, chocolate, those kind of things are bad before bed. What else would be bad before bed?
You're saying now that the lights and everything else from our cell phones,
Yes.
TVs, and everything else really does have that kind of-
They are. Computer lights, cell phone lights, those kind of things do affect. We don't realize it, but it is affecting our sleep-wake cycles. Medications can affect.
If a patient asks you not to interrupt them in the middle of the night, and you have scheduled medicine to give them, what do you?
Depends on what medicine it is. And if it is something that can wait, you need to call a physician. Sometimes they can just be rescheduled for later. Like say it's a medication that is on your schedule for 4 o'clock in the morning. I've often rescheduled it for 6. So at least it's later.
Okay.
Yeah.
Well, like, what about a blood sugar? Like
Checking their blood sugar.
Yes.
There's some things that have to be done.
Okay.
If they're in the hospital for certain things, they have to be done. And then you just have to, tell them, I'm going to be as quick as possible, but I have to do this for your own health. But there's a lot of things too that I think that we do in the middle of the night that we don't have to do. If you've got somebody whose vital signs are okay, have been fine, then there's no really reason to wake them up at midnight or 4 in the morning to get a set of vital signs. Or you may could get the midnight ones, but not the 4 a.m. ones. To wake them up in the middle of the night. There's always, respiratory patients have orders for incentive spirometer every 2 hours. Don't wake them up every 2 hours to do the incentive spirometer. Let them sleep. There's some things that we can do to promote sleep. Okay? So when you're asking them about that, you want to make sure that you're asking them all those things about their sleep patterns, their sleep rituals, their sleep cycle. This is a physical examination, obstructive sleep apnea, those are different things that if they're having trouble, a lot of people will keep a sleep diary. Alcohol, a lot of people think alcohol should make you sleepy, but it does make you sleepy, but it doesn't promote healthy sleep. Right. But don't you wake up still feeling tired?
Yeah.
Yeah. Depending on what you drink.
Bellyache.
Yeah. Wondering where you fell asleep. Okay. So the nursing diagnosis system, skip those for Ms. Walker. Sleep hygiene, we just talked about that, about how to get to sleep. Bedtime rituals. Creating a restful environment. Okay, so any questions about sleep? All right, let's look at that pain assessment in people with dementia article. What did you think about this? Interesting? How many of you work with patients who have dementia? A lot of you. Did you see your patients in this article? Yes, no, maybe, sort of. You didn't really care? Yeah. What did you find the most interesting about it? What do you think? What do we talked about how to assess pain. Is it a lot of nonverbal assessment with them? With people with dementia? What do you see with people with dementia? What kind of signs and symptoms? Aggression. Okay. Grouchy, grumpiness, change in their mood. Okay. What about restlessness? They become really restless in the bed. They want to climb out of the bed a lot. If you have somebody who's, a climber, that's when you see them mostly. You either know they're in pain or they need to go to the bathroom. That's when they're climbing out of bed.
Yeah, at night I had called Greg because this old man is sticking the window for a door and just want to climb out the window.
Oh, there you go. Okay. Confusion can increase. Maybe they're already confused, but it gets worse they're difficult to reorient. Okay. Let's look at this little quiz that you had at the end. Okay, the pain assessment in advanced dementia, that pain